Alright, so this is a training video for the surgical cricothyrotomy using the tube and bougie. We have trachea trainer, obviously, in beautiful Penrith blue. We have tube, bougie, scalpel, forceps, which are optional, and we'll talk about that a little bit later, but I always have them ready just in case, and obviously a syringe for the tube. What's missing is a bag, so because I'm at home, no bag, there won't be any insufflation at the end, but at least you can see the technique. In terms of setup, at Nepean we tend to do it from the right side of the patient. The airway trolley's there, the airway nurse is there, you've got all the defib and monitoring equipment on the left side of the patient, so it just makes more sense to have it on the right. And also don't forget that the surgical airway operator is going to be different to the intubation operator, because the intubator cannot have a few goes at a tube and then decide he's unsuccessful, come around the side of the bed and then start a procedure. If you make a decision to do the trachea, someone needs to be standing by ready to go rather than having any kind of 30-60 second delay just sort of moving. So that's how we do it. Have a think about that. There are a lot of very good reasons why we do it from the right of the patient. Other people might like to do it from the left hand of the patient, but I think at Nepean on standardisation we do it from the right side. Okay, so it's a pretty straightforward technique. I'll be going through it very, very slowly, describing each step and why we do it, and hopefully that will help for future procedures. Alright, so the first thing is obviously to feel the thyroid cartilage, cricoid cartilage and cricothyroid membrane. Now despite that, there's a lot of data to suggest we're not actually very good at that, and certainly in the stress of the patient, stress of the time, we might sort of not quite get it right. There is one emergency physician who probably a bit over the top, but I certainly bear this in mind whenever I intubate someone. He actually marks where he thinks the cricothyroid membrane is prior to each intubation, which, yeah, may be a bit over the top, but when it comes to the crunch, it's there for when you need it. Okay, but when you look at the incision, classical training is you do a longitudinal incision, because again there's a bit of doubt about where it might be, depending on how thick the skin is, how many neck, what the layers of skin are, whether there's lots of fat, patient positioning in terms of the chin forward, obesity obviously comes into it. So always a longitudinal incision, and make it 3 or 4 centimeters. You know, in the scheme of things, you're not going to worry about cosmesis, you know, when you find him wakes up from ICU. So just going through a nice long incision, starting at the thyroid cartilage, like that, and then the skin should spread apart a little bit, because it is elastic. You know, this is rubber, so it's not going to spread apart that much. Okay, I actually didn't cut all the way through, so again, make sure you've cut all the way through, and to get to the adipose, not necessarily right down to the cricothyroid membrane. Okay, the next part is right angles, so you're now in this plane of the patient, and it's basically a stab and twist. So you stab, okay, through the cricothyroid membrane. Yep, there we go. Okay, cut towards yourself, turn, cut towards the patient, cut towards the other side. Okay, the reason we're doing this is so that we have a big enough hole to put the equipment through. Now, again, always have something in the hole, and that's why we've got the forceps. I tend not to use the forceps because generally you can get the bougie in while the scalpel's in, okay, but never the good old finger, scalpel finger bougie technique. I think there's a lot of downside to that. When you take something out of the hole and then the skin closes up, lots of bleeding, you know, are you in the right hole, can you actually find it? You know, you don't need to ask all those questions. You know, the scalpel is already in the hole. Okay, so from my point of view, this is a pediatric bougie, which is a little bit easier to handle with one person. The adult ones, you often need a second person, and there should be some pediatric bougies in the airway trolley, and we're using a size 6 tube, so it totally fits with that. Okay, so we've got that in there. We put the bougie in, very easy. There we go, scalpel out. And of course, you're not going to cut any kind of balloon with the scalpel. because there's no balloon. Obviously, that's again the good part of having this the bougie in the start. And then never let go of the bougie, obviously, because you might sort of flop out. This is where maybe you're going to get your airway nurse just to feed the tube on, because you don't want to lose the bougie. Okay, and then once it's in, it's just a simple push just to get it in. Okay, I'm not actually pushing that hard. Alright, when you put it in, that black line, that's adjacent to skin. The reason behind that black line is when you actually intubate through direct laryngoscopy, that line is supposed to be level with the cords. Okay, so obviously the cords are kind of about here, so if the black line is to the skin, first of all, it's in far enough. Second of all, the balloon's in far enough, okay? And it's not in too far, because I've certainly done this in simulation and seen it put down the right main bronchus. Okay, that's all right, you just pull it back, it's not a big deal. But black line to the skin, bougie out. Now, I would normally insufflate at this point because hypoxia is a thing, and inflating the balloon does not fix that. Okay, so a couple of insufflations here. Clearly, I'm hoping I'm in, and I can't prove I'm not because I don't have the bag. Balloon in, 10 mils, pretty straightforward, and you're done. Okay, there we are.